Brilliant. So the topic of discussion today, when we were having a chat with Dr. Thakkar, we thought probably it's best to do some things that we, most of us are used to, things we encounter, things that are really going to benefit us from today going forward that we're going to be seeing. It's a pleasure for me to be here, discuss with you. So I'm hoping to make it as interactive as it can be, and probably we can be using the chat box for that. So the topic of discussion, as I've mentioned, I'm hoping everybody can hear me well. Let me put on my chat box just to make sure that so the chat box, yeah, if it's open there, can I just say just say yes for my audio is clear? Yes, thank you very much, Victoria and Jana. Good. So we're going to be talking about atrial fibrillation this afternoon in one of our sessions. I would want to think and believe that most of you have encountered atrial fibrillation at one point. And what we hope really to achieve, or we hope to start with the epidemiology of atrial fibrillation, spend some time on the pathophysiology and the clinical features, and hopefully conclude with management options for AF. We'll be doing, I'll probably be leading, but we'll be doing the work together. So the first one, the UK population is estimated at 67 million as per the most recent census. In your opinion, your estimation, what do you reckon is the estimated prevalence of AF? So if we just get a few answers, we have options A, B, C, and D. So I can see a D, most people, D, C, D, C, D. Okay, so it seems to be between C and D. Okay, very well. Nobody's going for A and nobody's going for E. Okay, very good. Okay, there is a B as well. Right, very well. So according to the most recent statistics from the British Heart Foundation, that's the report that came out earlier this year, it is estimated that about 1.5 million people in the UK have AF. But it's important to note that there is also over 250,000 people that are estimated to have AF, but it is undiagnosed. And we will discuss the relevance of that in due course. So I think the first thing is to note that, AF is something that is common. It's here to stay. You've probably seen it. If anybody hasn't seen it, it won't be long before you see it. Looking at the furthermore into the epidemiology of atrial fibrillation, the European Society of Cardiology statistical mapping shows that there is concrete evidence that it is more common in males than in females. So if we see the cumulative incidence, I'm hoping you can see my cursor there. So the men are in blue and the women are in red. We can see that these curves, the males have a higher incidence, cumulative incidence compared to the females. However, in the late years, about 80s, over 80s, as men we die off early, we have more men dying off than women because the average lifespan of women is a bit longer. So they live longer, getting more AF, and you see that the curves are coming together. But generally speaking, it is, more slightly has a more common to men than females. Looking forward, with all the technology advances in medical management, the projected increase in the AF prevalence, between 2016, this is the whole of Europe. So this is, up to 2060, not 260, 2060. I don't know if we shall be around or not. But if we can see among let's start with the red one. So between 65 to 79, there isn't much significant increase. Well, there's going to be a bit of increase, and the reasons for this can be debated. Increase in technology, we are becoming better at detecting AF, but then also people are hopefully becoming healthier, and the increase is not so much. But if we see over 80s, the increase is actually going to be more significant. And probably one of the reasons for this is, expected increase in people living longer. So we're going to be having a higher prevalence. And this is the total of the 65s. So generally speaking, we know that AF is something that is real. It is happening. We know about 1.5 of the population, 1.5 million of UK citizens have it. About more than 250,000 people have undiagnosed AF. Looking at the projections, these numbers are likely actually to be increasing. So it is probably worth spending some time to look at, what AF is, and look around, have a good understanding of the management and the salient issues relating to AF. So on the next slide, we look at the risk factors. This is all important information that we need for AF. This is the scheme, the summary that has been put forward by the European Society of Cardiology, looking at AF with the closer issues why people getting AF. As we've seen, aging is one of them, more common in aging populations. It's not that young people don't get it, but the prevalency, incidency is quite lower. There is an ethnic predilection. We've already talked about male sex. There is something to do with genetics. Those are the closest they put down to AF. But we know that a wider, the way we live our lives, there are also risk factors. We'll know that things like alcohol consumption, some of you will have seen maybe on the weekend, if you work on a Saturday or Sunday, A&E Gen Med, you get some 20, 30-year-olds coming in with palpitations after a binge drink, after stag do. We know that there is, if you get hypertension, it increases the risk of you having AF, heart failure. So there is a couple of things, lifestyle diseases. If you have COPD, if you've been on the respiratory ward, you'll see a proportion of them, it predisposes you to AF. Obesity, hypoventilation syndrome, obstructive sleep apnea, this combination, the Pickwickian syndrome. If you have a high cholesterol, coronary artery disease, if you're diabetic, CKD, all these things predispose you to AF. Okay, let's go to the next slide. So we have now established that in terms of numbers, statistics, AF is here. We also know that it is going to be here to stay. If anything, it's going to be getting higher. Why is it important? What's the impact of AF? Again, the European Society guidelines have summarized the impact of AF on people's livelihoods. So we know if that, the likelihood of dying is increased up to 3.5-fold mortality if you have AF compared to people without AF. And the mechanisms are summarized here. So it leads to excess mortality due to heart failure, strokes, and other comorbidities. Stroke, if anybody is on a stroke ward, they probably know if somebody comes in with an ischemic stroke, you probably, one of the things you're going to be doing is screening for AF, even paroxysmal AF. Even if they're in sinus rhythm, you're going to be doing a Holter monitor to check for AF. The mechanisms are here. Left ventricular dysfunction or heart failure, up to 30% of people with AF tend to get LV dysfunction as well. And the mechanisms are through excess ventricular rate, irregular ventricular contractions, and some other causes, primary underlying causes. We'll come back to these two mechanisms in due course, but you're basically likely to have heart failure just by getting AF. Cognitive decline, there is studies showing whether, regardless, even if you don't have a stroke, up to 1.6 risk, and the mechanisms are through hypoperfusion, microembolism that we do not see as big strokes. People with AF tend to have palpitations, breathlessness, reduced quality of life that can give you depression. Some people with even suicidal ideation. So it can, in fact, there is a psychological component on AF, impaired quality of life, as we've already mentioned, and all these indirect hospitalization with up to 40% annual hospitalization rate for AF or related complications. And this is really to highlight why we feel it's important to have a good idea, understanding of what AF is all about and try to manage as such. How do we manage AF? There have been different mechanisms, different strategies that have been put forward over time. The current one that the European Society of Cardiology has put forward is a simple one. Well, if you put up a strategy, you want it to be as simple as possible. So the strategy is called the ABC Principles for Management of AF. So if anybody, the hope is that by the end of this section, when you think about AF, you think about management of AF from an A, B, C perspective. And A is anticoagulation. So if person has AF, do they need anticoagulation or not? Why do we need to anticoagulate? We know to optimize, to manage to prevent ischemic stroke risk. You'll probably be already aware of the risk scores that we use for men and females, as well as putting into consideration the orbit score for bleeding and has bled that has been around for a long time. So the first question, you see a patient on your ward in A&E on the surgical ward, they have AF. The first thing is, do they need anticoagulation or not? And I'm relatively certain that you would be able to answer that question. The next thing is to think about symptom control, better symptom control. So symptom control with rate or rhythm control. We shall dwell on that a bit. AF has a tendency to go fast. It is irregular. You miss the P waves. It's irregular, different RR intervals. People tend to go fast. When the heart is going very fast, there is not enough relaxation time for the heart to fill. And that impairs, how much the stroke volume and the cardiac output ultimately. People become breathless. So we need to think about whether we want to do a rate control strategy, rhythm control. Then we want to look at comorbidity optimization. And this lends itself really to the previous slide of the risk factors for AF. So risk factors for AF, it's not just the heart. There are extra cardiac risk factors like hypertension, like smoking, like drinking, like BMI, physical inactivity. And all those are things that could be, smoking cessation, losing weight. So by losing weight, there is good evidence that you can reduce your AF burden by just reducing your weight, increasing your physical activity. Obviously, at some point, we'll discuss the vicious circle, the breathlessness that limits people from doing exercises. The psychological component, we need to look into that. Some people get depressed, some people cannot walk. If any of you has done some cardiology clinics, you'd see we have a significant proportion of young people who come in with palpitations, breathlessness, and we keep on doing Holter. We do rhythm symptom correlation. We see when they felt breathless, what was their rhythm like? So that it has a huge psychological impact that probably is a bit underappreciated. So main principles: anticoagulation, better symptom control, whether that is rhythm or rate control, and we'll be going in more details in that, and look at also optimization of other comorbidities, as we've seen from the risk factors. There are things we can't change. Well, almost things are changing now. I was going to say, like, your sex, you can't change male, female, but then I remembered, well, probably that is half true now. You could change that. I'm not sure if that changes the risk factor, but say your ethnic profile, you're not going to change it. Your genetics, you're not going to change it. Well, at least for now. Right. So after talking a lot, it's probably time to hand over to you guys as well to do some bits and bobs. So we'll go to a case number 2. So we have a 45-year-old male who's attended ED. The reason they've attended is because of palpitations that they've noted for the last 12 hours. Past medical history is nil. You're in A&E or you're in medical AMU. An ECG is done and there is AF with rapid ventricular response, say about 120 to 130. The patient is speaking to you, GCS is 15 out of 15, and the blood pressure is stable 120/75. As the doctor, as the attending doctor in first call, what are you gonna choose? What are the likely initial management options? Do we think we're gonna go for IV metoprolol? Are we gonna go for DC cardioversion? Are we gonna go for verapamil? We get some digoxin, or we get amiodarone and okay, so I'm seeing a couple of responses, C and B. It seems to be C and B. Right. Oh, well, they've gone well. So that's right. So a couple of answers. So most people seem to be thinking of B. Right. B, well, good. So should we? Right, I'm gonna choose one person. Well, let's get one person. B, but you can't be sure when the AF started. Charlie, yeah. Very good. Another one has chosen D. So shall we get one person to tell us why D? And can I say there are several options we can do, but we'll probably work out what the best option is. So that is the disclaimer. So yeah, there are a couple of options why we would choose other things, one thing after the other. And yeah, they are relatively right. I would agree with you, but probably one is better than the other. So does anybody want to give us a reason for going for D? Okay, people don't want to be put on the spot. Okay.
Please speak out.
Does anybody want to go for, tell us why D?
I was thinking if it's new onset first episode, a short history, which it seems to be from the case, then you can cardiovert them and there's not as greater thrombosis risk because of the short duration.
Brilliant. Good. So yeah, I think, I would completely agree with you. We could give metoprolol that is likely to slow down the heart rate, verapamil, digoxin. They're likely to slow down the heart rate. But yes, if it's for a short duration, yes, there is the option of cardioverting them. And I think that it would be the best option, as most of you have noted. What is the threshold for, so somebody has mentioned, it's for a short duration, where short stands for, if we just put in the chat box, short, what is the threshold? What are we going to be working? We have 12 hours here, but what is the likely threshold? What would you be using? 48 hours, brilliant, 24 hours. So I think it's going to be 48 hours. I completely agree with you. So yes, you could give them other options. And somebody says, sometimes you're not sure. I want to come back to that person. B, Charlie, yes, but you can't be sure when the AF started. Yes, Charlie, you're 100% right. The current guidelines. So if you have a young person who is sure when the symptoms started, we want to believe them that it started then. But you can't be 100%. I agree and I take that. If somebody is not very sure, just forget about it and go for rate control. So just to spend a little bit of time on that, when we have atrial fibrillation, you will have heard of the saying AF begets AF. When you have atrial fibrillation, there is remodeling in the atria. Atrial fibrillation is usually a function from the upper chambers, the atrial side, not the ventricles. And usually there is electrical remodeling. Just within hours of having atrial fibrillation, there is electrical remodeling, electrical changes that happen within the connections in the atria that are meant to propagate and maintain atrial fibrillation. But when we have AF even lasting longer, in terms of months, apart from the electrical remodeling, there is also structural remodeling in the, that, includes things from a spectrum of dilatation to atrial fibrosis. There is, the atria stretch out, pulling the electrics, and damaging the electrics. And that is likely actually to cause more AF or to maintain AF, or even when you cardiovert, you do not, you're unable to achieve sinus rhythm. So generally speaking, the earlier you manage it, the earlier you manage the rhythm, the better it is. Obviously, sometimes we do understand that you cannot, get rid of the AF, like persistent AF. That's another thing. But, the earlier we manage it, the more we can restore sinus rhythm. The earlier we can restore sinus rhythm, the better. Because the longer one is in AF, the more they become unlikely to come out of AF because of a combination of electrical and, structure changes. So it's very important to have that in mind. So yes, we could give metoprolol, it's likely to drop the rate. They might be in AF with ventricular response controlled, but yes, that is good, but not as good as restoring sinus rhythm. And just to mention to that further on that point, rhythm versus rate control. So when we do scans, echocardiography, they are different. So if we do a transthoracic echocardiogram, some of you will have seen similar pictures, but it's okay if you haven't. So we do a transthoracic, we put a probe at the, apical area. That would be around here, the apical area, and you're able to look at the heart in a 4-chamber view, like you can see. One of the properties, the good things about echo is then we can do Doppler studies. And when we do a Doppler study, we can put a line, send a line through the, so this is the LV, how? Because it is thick. And this is the RV, right ventricle, left ventricle. This would be, if this is the left ventricle, this would make this the mitral valve. This is the LA, and this is the RA. So we can look at blood coming from the LA into the LV. The Doppler, the echocardiography gives us ability to do Doppler scans and look at how fast the blood is coming in. And we can tell at different areas. So we can see how fast the blood is coming along this line, that is a continuous Doppler, or we can pulse, see at what level. So we can take a pulse at the mitral level to see how fast the blood is flowing in against time. So we call it pulsed wave Doppler. And when we do those studies, we can see that when people are in sinus rhythm, so the heart has contracted, it is going to relax. And when it relaxes, the blood that has all collected in the atria goes down the early diastolic filling phase, which is represented by this. So you can see a huge one, huge speed. And then the late part is the atrial kick. This is responsible to the P wave, where the atria contract to push the remaining bit of blood. So you can see that the amount of blood you're going to be collecting in your LV for your next contraction is going to be the sum of the early filling one and the atrial kick, But as we know in atrial fibrillation, so this comes up on Doppler. So this is in textbook stuff. When we do it, it is not as clean as this. So this is the real Doppler. So we have the E wave and the A wave. And what we are going to have the blood in the LV ready for the next systolic contraction is going to be a combination of this. And what happens in AF? So I've again borrowed this to show you this is what is happening in sinus rhythm, the early filling phase and the atrial kick. But we know that in AF, we've lost the atrial kick because we have disorganized activity in the atria. They're just fibrillating. There is no organized flow, no organized pumping of blood. And when we do the same study, Doppler, and we pulse, we check at that point the mitral inflow. We can see the early filling phase, but we've lost that function because the atria, they are no longer able to contract well in an organized function to pump in more blood in the late diastolic phase. And as a consequence, we are relying mainly on this phase, only the early filling phase. The consequence of that is that we're going to be comparatively in these two people, we'll be having less blood in the LV at the end of diastole. When we pump, we're going to be having less blood. We're pumping out, i.e. the stroke volume, and that is inherently linked with the cardiac output. So you have a reduced cardiac output as well. So with AF, people will be symptomatic, sometimes because of the rate at which it's going, but even if it's not going very fast, they can still, because they're going to be having a reduced cardiac output. I just thought I would spend some time to clarify that. And this, again, takes us back to what we talked about in the earlier question, that yes, we could manage with beta blockers, you could manage with digoxin, you could rate control them, but it's best if we can restore sinus rhythm. So this is from the physiological point of view. There is also good evidence. One of the biggest landmark trials is the East AFNET trial that was published in the New England Journal. And it shows that actually the earlier we get, earlier rhythm control is always associated with better outcomes. Message there is, wherever we can, rhythm control is going to be better. And if it's possible, the earlier is better than late. With also knowing that we cannot always achieve rhythm control, and we'll be looking at that further. So if we go to case 3, 52-year-old male attended ED, palpitations now for 3 weeks, past medical history is nothing, and ECG, again AF with rapid ventricular response, about 120, 130, GCS is like that, and again, the similar same options. Let's have a look. If we use the chart, let's see what people think we'll be likely to use.
Okay.
24? Okay, yeah. That was from the, so which option are people likely to use? So we have AF, 3 weeks, going fast, but stable. What do people want to give? Do you going to give metoprolol, DC cardioversion, verapamil, digoxin, amiodarone? So C, verapamil, okay.
Yeah.
Somebody, I think somebody is on the phone, needs to mute. Yeah. Okay. Joe, C, okay, very well. Yeah. Any options? A, IV metoprolol, C, yeah, A, C. Okay. So I think the point there has been, I think the point there, I can see that people do recognize. Yeah, so I would agree with you. You could go for metoprolol, you could go for verapamil, but as long as you steer away from option C. I mean, option B, DC cardioversion. And as I think it was Charlie who mentioned to us before. So this is because AF, we've had it for quite a while. And yeah, we could go for rate control. So we could rate control with any of the above. I think we need to stay away the main things, as long as you choose anything minus B and E. I think the options there that we should be staying away from would be cardioversion as well as amiodarone, and the reason is because it could cardiovert. And if we know that if people have had AF for more than 48 hours, there is a risk of.
There's a question, Joseph.
Yeah. What would make you choose option A over A? Do we know where the
Ahmed.
Yeah. Okay.
Ahmed Al-Husani, your camera is off, and there is some sound coming from your audio. Could you make sure you're on mute, please? And have your camera on. Thank you.
Good. Thank you, Dr. Thacker.
Yeah.
Could you guys
Would you
ring
say just kind of wait
your
till
colleague
the
if you have
MRI is
their
fine?
number and ask them to,
Explain the result.
perhaps they might not be engaging with the session, I'm not sure.
Yeah.
I've tried to mute a couple of times.
Okay, thank you for
Let's
sorting
carry
that
on.
out. Right. So that is Nevlin.
And so she's also,
Nevlin.
we're just waiting for one of the other consultants to say that she made it up tomorrow. And I hope that can be this week at some point, so she could potentially be discharged for the rest of duty.
Does anybody have the contact for that person to mute the?
Yeah.
Because I can hardly hear myself, let alone you hear me.
I've just sent him a WhatsApp message, so hopefully he'll respond quickly.
That's very kind. Thank you very
Okay.
much. I've tried to mute a couple of times and
It's just not working. Yeah. Okay, that is better. So Nevlin, I think really, generally speaking, option A would be all right, option C would be all right, and option D would be all right. I think the things to stay away from this would be B and E, DC cardioversion and amiodarone. There are a few issues when you would choose verapamil and metoprolol or digoxin, but I think the point there is we can't get rate control. And, you know, things like if one has asthma compared to the other, how the LV function is. So is there a reason why you would go for metoprolol over bisoprolol? Is that more effective? Well, I'm not, I wouldn't think, we don't have IV bisoprolol. So bisoprolol is always going to take a longer time. Metoprolol, you can give it and get the effects there and then. But otherwise, even if I had bisoprolol here, I would accept it. I think the point I'm trying to make here is whichever you use for rate control for your reasons, I'm happy with it. But if we could stay away from electrical cardioversion or chemical cardioversion. And the point there to make is that, you know, you've had a clot for over 48 hours. It's 3 weeks. You're likely to be having a clot in the LA. And if we cardiovert, so before the atria, we're just fibrillating, not doing anything. We remember Virtual's tried. We have stasis of blood. We formed the clot. And if you get it in sinus rhythm, now you have the ability to pump forward well. And that is going to increase the risk of stroke. So if you're ever going to do, if you want to choose any of those, then we need to be able to do a transesophageal echocardiogram to make sure that there is no clot in the left atrium. So whichever answer you would have chosen here, I'm happy with it, and it would work. Some would work earlier than others. But, you know, if you choose that, if you're to choose cardioversion, chemical, electrical, at that point in time, you need to do a TOE. If we don't have a TOE, then we have to rate control, start people on oral anticoagulation for about 3 weeks, 3 to 4 weeks, and then plan for elective cardioversion. So probably this electrical cardioversion, I should have put immediate or elective. So is there a reason why, what would you choose? I would choose either A, C, or D. In my practice, usually when I'm on call, I go for IV metoprolol. You get the things there, and then A and E is happy. You get bed movement of patients. Then after, when you give them metoprolol, the one thing you need to know about metoprolol, it's quick. You know, it gets in there, but it also stays for a short time, 1 hour to 2 hours. So you give them metoprolol, you rate control them, but you need to start them on oral bisoprolol as well, so that by the time the metoprolol is wearing off, the bisoprolol has kicked in. Otherwise, you rate control them. The ED reg is happy with you, but as you go to clock back another patient, they will be calling you back because the patient is back in a rapid ventricular response. So,
what dose of metoprolol would you recommend to the group? Sorry? What dose of metoprolol?
So we would usually, if it's IV, we would start with the 5, and then we repeat it up to 3 times. Yeah, blood pressure is the thing to make sure. If people are intolerant to beta blockers, you probably go for verapamil. Digoxin is going to take a bit of time. Yeah, if you know that they have severely impaired LV, you probably don't want to go for a calcium channel blocker. But those are nitty-gritties will go. The role here, the point here is, let's rate control. No, if we want to immediately cardiovert, we need to do a TOE to ensure that there is no clot. If we are unable to do that, we need to rate control, start on anticoagulation for about 3-4 weeks, organize for an elective cardioversion. And the reason, again, we are trying to cardiovert is to go to sinus rhythm, to restore sinus rhythm. So we are trying to restore sinus rhythm as soon as we can, either using TOE-guided cardioversion or elective cardioversion after anticoagulation, because we know that restoration of sinus rhythm has better outcomes. Okay. So in a nutshell, we've talked about management strategies. We've talked about when we can immediately cardiovert, less than 48 hours. If we have uncertainty, there is no point of managing to cardiovert. Use a TOE if you can't, which you're never going to get anyway, immediately like that. Nobody's going to be coming early like that. Rate control, put them on anticoagulation, elective cardioversion. We can cardiovert using electricity or amiodarone. And then we will come to catheter ablation in a bit. Case form, 58-year-old male attends ED with palpitations and shortness of breath, reports on and off palpitations for the last 3 months. ECG shows AF with rapid ventricular response. BP is stable. Bloods, always remember to check bloods. TFTs is something that is normally forgotten. Everybody going slow or fast. We need to remember hypo and hyperthyroid. The electrolytes for the topic of today's discussion, they are all okay. Past medical history is normal and the echo is okay. As you prepare to speak to your colleague or get whatever medication you have in mind at the moment, the patient reverts to sinus rhythm. What would be your management plan? Do you send them home with amiodarone? Do you give them flecainide, pill in the pocket, flecainide, bisoprolol, or consider ablation? Let's see what people think in the chat. So C initially, D bisoprolol. So the answers seem to be between C and D. Very good, very good. C or D, yeah. And actually, so Hira, I think Hira, you've said, Hira Riz, you've said C or D, but actually you can also do C and D. So yeah, so yes, you can give them bisoprolol. So if I tweaked it, they are having these intermittent, well, here they've had on and off. So if somebody is having palpitations twice a year, would you start them on a beta blocker? Would you start them on a regular one? So the answers can vary depending on the frequency of these palpitations. If they are more frequent, you want to start them on something regular. If they are very spaced, you probably want to try pill in the pocket. It's a strategy that has been used, but there is also drawbacks to it. Many people, before they even swallow the flecainide, or the rhythm has already set back. So this is going to manage things, but remember what we talked about. So we can use all of those options, but actually we've talked about restoration of proper sinus rhythm. Well, they've gone back to sinus rhythm, but they come on intermittent. They have paroxysmal AF. So the best answer, my answer, whereas all the answers are true, and I've probably done a couple of them different times, the best answer would probably be to consider, pulmonary vein isolation, PVI ablation. And when I say that, it's actually not on its own. So you could use bisoprolol, and then you consider PVI. You could use flecainide and use PVI. And just to spend some time on that, so we know we have permanent AF, persistent AF, and a paroxysmal AF. So when we look at a specific subgroup of people with pulmonary, this is PAF, paroxysmal atrial fibrillation. There is evidence when that 94% of patients with paroxysmal atrial fibrillation, the triggers are around the pulmonary veins. So it's been known since 1998. So this is a study that this is a model of the heart in a triangular. You can see how good medical people are at drawing. But basically, this is the right atrium, and this is the left atrium. Superior vena cava, inferior vena cava. This is the septum. So we have the the superior and inferior pulmonary veins. And when they mapped out, when they did this study, they showed that actually most of the triggers for this AF were coming around the pulmonary veins. And that, you know, is some of the evidence behind what we call PVI. Some of you will have heard of that term, pulmonary vein isolation. So a good proportion, up to 94%, if patients come in and they have paroxysmal AF, paroxysmal meaning intermittent, it's on and off, the triggers in 94% of them are likely to be around the pulmonary veins. And this is at the histological level to show, you know, you have this is the left atrium and this is the lung side, and where the veins, the pulmonary veins are coming from the lung into the heart. So where you have the myocardial sleeve, where the vein, you know, you have less of the vein. So this side you have more vein, less atrial, and it is the other way around, more atrial at the sleeves. This appears to be the problem, the veno-atrial junction. This appears to be the problem in majority of the people that are having pulmonary, that are having paroxysmal atrial fibrillation. There is evidence to show that there are a couple of ways that they think that it is thought why this area is the problem. The mechanisms are about 4 mechanisms. There is evidence to show that, you know, pulmonary veins around there, they have independent pacemaker cells that initiate contractions and cause these AF fibrillations. There is that is increased automaticity. Generally, the mechanisms are around 3. The other one is triggered activity after a normal contraction. There is early and delayed after depolarizations around that area that keep on keeping that area electrically active. But also the difference, so the other one is re-entry mechanisms. The fact that you have different tissues, it means they have different conduction properties, and that is it's a substrate for re-entry tachycardias. Anyway, whatever the mechanism is, there is good evidence that if you're able to isolate the pulmonary veins, you can actually restore sinus rhythm. And people, so if you have young people, say less than 60, relatively new, couple of months, paroxysmal AF, first PVI, the success rates are over 75, and second PVI, they are over like 95% in good hands. So you can actually restore sinus rhythm. And that is to lend ourselves again to what we discussed earlier, that, restoration, having sinus rhythm is always better than AF, even if it is rate controlled. This is a picture to sort of show what happens, ablation. So according to the ESC, ablation, actually now, if we ask this question to the ESC committee, the answer, they show that ablation is as good as drug therapy. So what they usually do, so this is the pulmonary vein. There are different ways, techniques, the commonest being common ones. Commonest is always subjective, depends on where you're talking from. So they can, pass through, this is the inferior vena cava, send in through catheters, ablation catheters, locate these pulmonary veins, and you can use cryoballoons to electrically cut off those pulmonary veins, the electrical. So you ablate around that. There is other ways of burning using electricity. This is cryotherapy. The others, they use electricity to burn the area, but it's called basically pulmonary vein isolation. And you can cure AF with very good rates. It's something that is being advocated for, and in the current guidelines at the ESC, it is a 1A recommendation for paroxysmal AF. In fact, there is some suggestive data that it gives you better, it reduces, there is a suggestion of even it improves mortality compared to drug therapies. Things also to bear in mind here, if you say drugs, so whichever drug we're going to use there has also side effects. Bisoprolol is one that probably commonly we shall use for that, but bisoprolol has its own side effects, including erectile dysfunctions. If you're having football players who don't want young people, you don't want them to be on, 32-year-old, you don't want them to be on drugs for a long time, you can use this. It's something worth it knowing. And in fact, if you meet anybody who has PVI, who has paroxysmal AF, it is always worth it having a chat about the need for PVI because it is quite successful, and there is good data for why it's probably even ahead of it. That's another debate. Compared to drug therapy, the evidence, the recommendation from the ESC, it's as good, but there is some evidence that's coming up that ablation is better than drug therapy. So it's something for you to remember. You're in A&E, see a patient, paroxysmal AF. Remember that you can't choose whichever options you choose, but you probably don't want people to be having medications for the rest of their life. You can't always restore sinus rhythm throughout. So rhythm control, this is some of the evidence again behind rhythm control associated with better outcomes, as we have already discussed before. Right. So Dr. Thacker, I'm not sure, I had planned to go for a few minutes break at this point, but I can see that time is going. I don't know if you're happy for me to just go through.
Yeah, I think it'd be good to wrap up and then give them.
Yeah, because I think we've lost some time from.
And then, I mean, you may wish to cover the appendage.
Should we give? So I can see we are at. Is that 5 minutes to?
Oh, it's 8 minutes to 3. So you could, in a couple of minutes, just give them an idea about the appendage occlusion, and then wrap up.
Okay, brilliant.
Okay,
Thank you very
thanks.
much. Good. Right. Hope that is clear. So the next one is 18-year-old male attended ED with palpitations and dizziness. No past medical history. BP is that. GCS is that. You do an ECG and it gives you that. Options that we are thinking about. Are we going to metoprolol, verapamil, electrical cardioversion, digoxin, adenosine? We've lost some time due to the noise interference, so we're going to be a bit high. Give it maybe 20 seconds. Okay, E, adenosine, E. Very good. Very good. Thank you. So I think this brings out the learning need. And so this is one ECG that I hope you all can go away with. So E is the wrong thing to do for everybody. So this is an ECG of AF with aberrancy. So the option we want to go for is C, and to go into that. So remember this ECG. So on the topic, there is what we call pre-excited AF. We already know pre-excitation, Wolff, Parkinson, White. So if, you have an accessory pathway that we already know. So if people have an accessory pathway and they get AF, this is what they are going to get. A bizarre-looking ECG. It's not anything like VT, but it's big. It's because the AF is using both the AV node.
Yeah, I think that's a very important ECG. You don't want to go back to it, and then perhaps maybe people should look at the ventricular rates at the fastest points.
So you can see that it is irregular. It's going very fast.
Could you type in the chat box as to what the ventricular rate would be at this point, where my arrow is, this point approximately? And is that compatible with circulation or life? Anybody, please?
There is no arrow. I can't see it either.
I can't see an arrow.
Well, just see in the middle of the trace.
If you see this, can you see how fast? Can you see my arrow? So how fast is that? If you see from here to here, that's about 300, yes. So there it's going at 300, but here it's gone a bit slower, as you can see. So it's irregular. So the rates are probably between 250 and 300. Remember, we said the faster one goes, the shorter the diastolic phase, the less the filling time. So you're going very fast, but your pumping efficiency has reduced. People are going to collapse. People are likely to pass out or die from this. So this is one of the important ECGs we would want you to know. And the main thing is, if you give adenosine or any of the AV node blocking drugs, they are going to stop this and encourage use of the accessory pathway. And if we do that, this is what is likely to happen. because we've stopped. You can think of it as VT. Yes, you can think of it as VT, but remember if you're not sure, electrical cardioversion, because if you block the AV node, you're encouraging the accessory pathway to take over. So the definitive, so if they come in electrical cardioversion, that is going to restore sinus rhythm, hopefully. But it's important to remember, don't let that person go home, because they will have another episode of AF and they might pass out, they might be alone, they might do what. So it's always important to refer them for an inpatient ablation of the accessory pathway. So this is, a small a cartoon picture to show what happens. In EP studies, electrophysiology studies, there are different branches of subspecialty in cardiology, and one of them is electrophysiology. They put different catheters in the heart. This is the LV, RV. This is the RV catheter. This is the coronary sinus catheter. They put another one in the RA, and then they can map out where the accessory pathway is, and they can burn it. And that is the definitive treatment for those patients. You might electrocardiovert them, they are looking all right, they go home, they have another event and they pass out. So this is how it looks in cartoon, and this was a picture to show you what happens in real fluoroscopy, passing from the inferior vena cava. This is the RV catheter, coronary sinus, this is the RA catheter, and this is the ablation catheter, looking for wherever they can work out where the accessory pathway is, ablate it, and the patient is cured. Right, do we have time? I think we'll do, well, let's see how far we can go. I'll stop at hopefully at exactly, I have 3 minutes. Let's do one last one.
Sure.
70th, this is another case you're likely to meet. Chap has come, he's 75-year-old. He's coming with, he's known to have AF, hypertension, and he's a smoker. He's taking amlodipine and apixaban, and has come in, and, clinical assessment suggests that he has an NSTEMI. What is the recommended treatment? So patients with AF and NSTEMI. If we can put in the chat, we have about 3 minutes. See which options, why. So are we going to give them standard treatment, Fundo, aspirin, Clopi, stop the apixaban? Are we going to give them Fundo and Teca aspirin? It is an emergency AF with pre-excitation, needs DC cardioversion and inpatient. Yes, thank you very much, Dr. Taka. So A, Fundo, aspirin, and Clopi, which is standard treatment. B, Fundo, aspirin, and Teca. So if you haven't met this patient, you'll be meeting them, and the next time you're probably even on call. Yeah. So patients who have AF and they come in, how do we manage them? So this is one of the concerns, you're likely to meet. Remember, we anticoagulate for ischemic stroke prophylaxis. So if we give them Fonda and then B, so there is clear guidance about that. And patients who come in with, if patients have AF, we needn't stop the oral anticoagulation. But what we could do, we need to give them triple therapy, that is a DOAC, NOAC, plus a dual antiplatelet, that is aspirin, with a P2Y12 like clopidogrel, Tecaglol. The most preferred one is clopidogrel. So aspirin, clopidogrel, and their apixaban, edoxaban, warfarin, whatever they are. The preferred is for a week. And then depending on whether they have high risk or small, high bleeding risk or high ischemic risk, we look at triple therapy going for up to a month if we think it's high ischemic risk. But if we think the high bleeding risk, we give it triple therapy for just 1 week, and then move to dual therapy. That is the anticoagulation and a single antiplatelet. So the thing to note is, don't stop the oral anticoagulation. It is what you add onto it. And there will be definite variations on when you stop, but this is the recommendation. If you give them the standard treatment, you're going to be leaving them prone to their stroke. Okay, seeking anticoagulation. Dr. Thaka, would you allow me to do one last case?
Go on. We're literally full with time, so maybe very quick.
Brilliant. So, 32-year-old, he's known to have HOCM has been detected with AF on a Holter monitor, it's been referred to you, you've not got a busy clinic, so you've been able to do the CHA2DS2-VASc score and it comes up to 0. The GP is asking you for anticoagulation advice. Are we gonna start them on aspirin? Are we gonna give them their CHA2DS2-VASc score is 0? Are we gonna give them oral anticoagulation? Are we gonna so give them nothing because their CHA2DS2-VASc score is 0? Good. So because of the interest of time, we shall again move on. So this is a special category of a special subset of people. The CHA2DS2-VASc score does not cater for them. So that was a trick question. Forgive me for bringing that, but that was the whole point, to emphasize that learning need. That CHA2DS2-VASc is not accounting for people with HOCM. The first detection of HOCM, you start on anticoagulation regardless of the CHA2DS2-VASc score. So I think this is in the management, this is to show you where the recommendations in the guidelines, patients with hypertrophic cardiomyopathy and clinical AF anticoagulation is recommended with direct anticoagulation independent of CHA2DS2-VASc score. So regardless of what they are, the first line recommended, you can use a DOAC, but if you wanted to use warfarin, well and good. It's a second option. So appendage, okay. As we wrap up, this is the last case, I promise. 78-year-old with hypertension, benign prostate hypertrophy, has had an intracranial hemorrhage 3 years ago, has new AF. Anticoagulation advice? So they've got a risk of bleeding, but they need anticoagulation. Because we've talked about the ABC strategy. Remember, do they need anticoagulation? He needs anticoagulation, but he can't have anticoagulation. So people have gone for warfarin. Right, so this identifies another learning need. And this is the left atrial appendage occlusion. So they are a subgroup of patients who need anticoagulation because of their CHA2DS2-VASc score. They need oral anticoagulation, but they're unable to tolerate anticoagulation. Why? Because they've had a major bleed in the brain, a major GI bleed, catastrophic bleed. They have a bleeding risk, hematological risk. What do we do for those patients? There is something called left atrial appendage occlusion. So if we have the heart, this is the LA, it has something which they call the left atrial appendage. So this, if it is closed off using devices or surgical means, so we call it left. So this is the common one, Watchman left atrial appendage closure device. It's made by Boston. It's well studied through PROTECT. A couple of trials have been done, and it's shown for those patients who cannot tolerate anticoagulation for the reasons we've talked about. It's always something to think about. So you people who are on the care of the elderly patients, people they can't tolerate anticoagulation for some reason, but they need ischemic stroke prophylaxis. There are studies that show that left atrial appendage occlusion, whether surgical means, whether using these devices, is non-inferior to anticoagulation. This is something that is being done in Leeds. Lee Graham does it. This is how it happens. You occlude it for those patients who can't take your anticoagulation. In fact, there are some patients who have high risk also taking anticoagulation, but it can be used as a complement system. These are surgical ways to occlude that, and head-to-head appendage occlusion versus anticoagulation, it is shown to be non-inferior. Right, so we shall skip that in the interest of time. And summarize by saying that generally we have looked at the prevalence statistics, the epidemiology of AF, and we know it's already here and it's likely even to increase. We have looked at the risk factors. They can be both cardiac and extracardiac, as we've seen. And we've also explored the different management systems within the ABC strategy for the different populations. And that is as much time as we've had. Thank you so much.